Do you think there's the possibility that practices may become bankrupt?
Yes, I do think so, but it's a slightly different question. The healthcare budget that the practices will manage on behalf of their patients is to the overwhelming majority not practice income. That's other providers, hospitals, social care, community care and so on. Nevertheless, the GMS, PMS contract sum, or whatever the new GP contract will be called, will come under pressure. Clearly, by moving more care out of secondary care to save money, will come into primary care. So primary care will not be able to carry on as is, but will have to think about GP productivity. Right now, I don't think anybody has a clear understanding what that actually is, but that's a question we'll have to face and see what patients do you as a GP spend your time on most productively and really make a difference. So I think GPs will have to become more selective, and maybe a patient that has only a cold and gets better within a couple of days anyway is probably not the most productively spent time, if you see. So that will shift, I think, what primary care actually does. And if a primary care practice does not change its way of working, either it will be flooded with work and they can work until midnight and Saturday and Sunday through, or have indeed a cost pressure and might go out of business for that reason. So I think there will be a significant push on practice efficiency and productivity.
There are many GPs who feel disinterested in the financial implications of their clinical practice. How do you think we can engage disinterested GPs in the commissioning process going forward?
I think it's a bit of a naive view to think as a doctor that I don't care about the money. I just look after my patient and spend whatever I please. I agree, I'm a doctor, I'm a neurologist myself, typically sort of looking after relatively expensive conditions that I obviously would try to provide the best care for the patient. On the other hand, if I squander money on something that doesn't really justify better outcomes, then I have withdrawn resources that could have spent on another patient. And if I close my mind to that trade-off as a doctor, I'm just being irresponsible with healthcare funds. You can do that if there's endless money coming, but I don't think we are in that situation anymore and never actually have been. So I think it is a responsibility of the doctor to think about how to spend healthcare resources responsibly. If a doctor does really not want to engage in that, I think the doctor doesn't take his job seriously and should be really reviewing whether they have the right to see patients. And that's quite a radical view, but I think doctors have to live up to that. Now, I don't say that every doctor has to become a manager. For that, as a doctor, you should work within a group and so on, and have management that looks into how money is spent in performance and all the rest of it. But a doctor should be open to a discussion amongst colleagues to see in what way excellent patient care can be provided at the best cost. As long as the doctor is engaged in that process, that's what is needed, and the doctor should get on in looking after patients, because that's what they went to medical school for. It would be crazy to make them all into managers. That's what you have trained managers for. So the two have to work together. But I think it's not viable for a doctor to say, I don't care about the money. That's just not on.
Should we be given, as it were, till receipts at the end of a week or a month about how real-time till receipts, so how much money we're spending? Would that be something that you see happening in the future?
You absolutely need real-time performance reports. Weekly is great. Now, whether that are till receipts with only a tally of the total cost created that week, I'm not sure is the right answer, because that will swing a lot and you can't really make a good judgment week on week. But nevertheless, you have to create metrics that are practically relevant for you in your daily job, and that you get fed back immediately. It's no point having feedback half a year later, because A, you can't remember what drove the cost at that time, and so it doesn't engage.
Do you think there should be more involvement and integration between primary and secondary care?
The team or care team with GPs and consultants, as well as community healthcare workers, is absolutely essential. The biggest inefficiencies in terms of finances, but also in terms of poor outcomes, is exactly in the lack of the interface, where every organization, the GP and the consultants, all provide an excellent service in their own right, but when the patient crosses from one to the other, things fall apart. And that's, I think, the main bane of the NHS currently. I would expect consultants to jump on the opportunity to not be confined within their hospital and have got no connection with the GPs. When I was a practicing epileptologist, I was very frustrated that I really, in order to have an epilepsy center, need a catchment population of 3 to 4 million people. So I need to make myself much more accessible to my GP colleagues. I can't possibly see all epilepsy patients out of 3 million people. At the same time, I need to see selected patients much more readily. So right now, the danger is that over the course of the pathway, primary care pushes specialist input further out in order to preserve costs, which is A, bad for patients, secondly, false economy, because you sit on patients that could have probably been dealt with cheaply earlier. And secondly, you have got a whole cadre of highly trained specialists that should do their specialist job and help patients that have special needs rather than being kept away. So it will be very important for the consultant body to engage and not become defensive and see how they can break down the bricks and mortar boundaries of the hospital and become part of the pathway. So we try to have specialist input early in the pathway, not necessarily by referring everybody to a consultant appointment and racking up tariff costs, but to see how can a cardiologist give early input and guide the rest of the pathway much more efficiently. And I think that overlap integration is the biggest opportunity that we have, and that's what we need to get operationally sorted out.
Coming on to ISTCs, do you think the current situation where we have contracts that are paid for regardless of the workflow that comes out of them will continue in the future?
I can't imagine that ISTC contracts after their 5-year lifetime will be renewed in the same way that they were set up in the first place. Also, the first 5-year contract included a premium cost to repay the capital cost to set up the ISTC. So once the 5-year contract is over, the NHS owns the ISTC. A new provider does not have the right to any further additional capital repayment. It was paid. So thereby some of the ISTC costs should come down. Now the question is, how do you manage a block contract where you prepay for minimum volume and then you don't fill it up? So that's obviously a bit of an interesting way how to finance it. Again, probably to make private investors find it attractive to enter the market, but I don't think that in the second iteration of ICC contracts that has to be the case. I would expect that to be a much more competitive field of multiple providers without any guaranteed contracts, and the attraction for any provider, NHS or ISTC, will be to form an alliance with the local managed care organization that I referred to earlier to become the provider within that pathway. But that will be a competitive field and not pre-agreed guaranteed income.
There are some concerns that we're headed back to 1980 style waiting lists in the NHS. Do you think that's a real possibility?
Are we going back to the 80s waiting lists? I think there's a risk of that. The fundamental question is government serious about decentralizing and devolving decisions, or do the centralists win? And in which case I think we go back to 1980s style. Let me just paint that threat as a picture. If we have further heavily centralized control, the main lever that a central control healthcare system has is to restrict capacity, because basically they have to face supply-induced demand. From Whitehall, you can only turn down the capacity screw, which means at some point you end up with waiting lists as an inevitable consequence. So that's the bad scenario. The risk, I think, is very real, because if indeed GP commissioning consortia are created in a way that basically replicates PCTs, you really haven't brought clinical decision making and financial accountability together. The main risk is that somebody gets too scared of the conflict of interest of providing and commissioning and starts pulling the GP commissioning consortium back to what the PCT is right now. That will lead back into central control, and I think waiting lists will become inevitable given the cost pressure. There will be not enough slush money around to just buy down the waiting list and not worry about the financial consequences. If government is serious about devolving decision rights and can manage the inherent conflict of interest between commissioning and providing in the person of the GP, and can do that, I think the opportunity is great that managed care organizations together with the alliance of local providers will be incentivized to not have waiting lists. And I think just from a efficiency potential, there should be so much efficiency potential in the system that waiting lists absolutely should not be necessary.
Will patients start worrying that the GP doesn't have their best interest at heart but has a financial interest at heart?
In any healthcare system, that's a fundamental conflict, whether you've got private insurance or not. There's always a situation that the money paid for healthcare is limited and the services potentially could become unlimited, and the patient will always have the trade-off. If you're private insured and you want to have a procedure done, you need to ring the insurance company for pre-approval to making sure that's what is covered. I think in the private insurance world that's a much more transparent situation, because the insurance paying member of the insurance scheme knows ahead of time as to what services they basically purchase, and if they want they can buy a more expensive product. The tricky part is with the NHS, it's tax funded. You don't have the decision as a tax-paying public member to say whether you want more or less services. So thereby you create a situation that you always expect to get everything on the NHS, and at some point you run out of cash. And that, I think, is ultimately a regulatory function that NICE and national committees will have to decide and make clear to the public that not everything can be paid by the NHS in unlimited quantities. And that's a responsibility, I think, of the politicians, to be honest, to our population. Within that, I think, as a GP or as a doctor myself, the fundamental defense against that claim that we're saving money at the cost of patient care is to be very transparent with outcomes, to show that our outcomes are better than, or at least as good as anywhere else in the country, or ideally better than they were last year, and to involve patients very actively in these trade-offs. I think there is a fear to discuss financial matters with patients or patient group, but that creates only more of a hidden discussion that patients get more anxious about.